All right, so I'm Sabine, for whoever doesn't know me. I guess everybody should know me by now. I'm one of the pediatric nephrologists who works here. We're sort of going to go, this is a very basic grand rounds, kind of goes over how your kidney develops, what your kidney function is, what a creatinine value means, and how do you calculate the GFR when you get the call from the MRI saying, we need a GFR before we'll take your child to MRI. If anybody has any questions at any point, just stop me and ask. I don't mind. If I'm going too fast, you can slow me down. Okay, so this is a statement I have to put up there for CME purposes, so here it is. All right, so as I mentioned, we're going to go kind of through the structure and function of the kidney. We're going to try to understand what the development is, what factors influence the pre- and postnatal development of the kidney, so that it kind of helps you manage them when they're born sooner than they should be and they're in the NICU, and then how to estimate the GFR. So first of all, let's move on to the structure and function of the kidney. Okay, so the kidney lies in your retroperitoneum right here, and is then kind of covered by the liver and a little bit by the spleen on the side. And then you can see kind of it feeds directly into the vena cava for its renal vein supply on one side, and kind of travels a little on the other side. The renal arteries come right out of the aorta. Sometimes you'll hear words like duplicate renal artery or aberrant renal artery, which basically just means that one part of the kidney is supplied by an extra artery. That information becomes more important when you're trying to see if somebody is a candidate for a renal transplant donation, because then you have to know how many arteries and how many veins they have. Then you have these ureters that come down and then empty into your bladder, and then you pee your urine out. So things you will hear and terms you will hear would be your renal pelvis is right here. So if you have UPJ obstruction, it's up here. If you have a UVJ obstruction, uretrovesical junction obstruction, it's down here. So if you keep the anatomy in mind, it kind of helps you understand all the terms that are thrown out there by us and urologists together. The other thing to remember is when you have a kidney transplant, especially in a slightly older child, that kidney transplant sits right here in the pelvis, and it's extraperitoneal, and it is an anastomosis between the iliac vessels and the renal arteries of the donor kidney, and then the ureter from the donor kidney goes into the bladder. So transplant kidneys are not back here in the lumbar area. Most of the cases, the native kidneys are left in there, so essentially the child will have 3 kidneys for a while. So just things to keep in mind when you're evaluating somebody who has transplant kidneys, and etc. So coming to the kidney itself, there's a renal capsule on the outside. So your kidney can, if it decides to bleed into itself, or if it's swollen because it's very nephrotic or something like that, it can expand to a certain amount, but then it's covered by a capsule, and so it cannot expand anymore. So essentially the kidney can hurt. So if somebody says their kidney hurts, it can hurt because there's a capsule around it and it's fibrous, and so it can only expand that much. Then you have your renal cortex, and you have your pyramids, and you have your medulla. All your glomeruli, the functional units of the kidney, kind of lie in your cortex, and then you have your tubules, and that forms the urine. The urine goes into the calyces, the pelvis, and then down into your ureter. Okay, here comes the nephron. All right, we're going to go into the nitty-gritty details. So everybody, well, the medical students will be the freshest, I guess, in the renal physiology. So at this point, maybe I should start asking questions instead of telling you guys what is what. All right, so your nephron is the one single unit, functional unit, out of which there are lots of per kidney. So your nephron starts, it is fully formed by 36 weeks gestation. Another thing to keep in mind, when our preemies are born at 25, 26, 28 weeks, their kidneys are not fully formed. So every poison we throw at them will hamper the development of the kidney. So that's why all those preemies are more prone to having problems later in life as far as hypertension and chronic kidney disease is concerned. So your kidney receives about 20% of your cardiac output, which is quite a bit. So we're an important organ. All right, so you have your glomerulus, then you have your proximal convoluted tubule, your descending limb begins, you have your whole descending limb, ascending limb. This is essentially called the loop of Henle, and we'll go through the details of all of these in a second. Then you have your ascending limbs, your distal convoluted tubules, and then collecting duct, and then you go down to the bladder. Okay. So your major kidney functions, kind of, since we're going to go through it in a little bit, is most importantly, obviously, it produces urine, gets rid of toxins from the body, yada yada. But it regulates your electrolyte concentrations of pretty much all your major electrolytes, regulates the extracellular fluid volume, regulates osmotic pressure, helps with acid-base balance, helps regulate blood pressure, eliminates waste products, drugs and toxins, and produces hormones. So kind of going through how, where, what happens is, so in a nephron every day, essentially, every single nephron gets your blood from an afferent arteriole and leaves and then kind of passes through the kidney, and then the vessel going away from each glomerulus is the efferent arteriole. And the pressure between these two vessels is what determines how much blood is going to flow through each of these filters. About 180 liters of fluid, or blood fluid, a day passes through the glomeruli every single day. But we don't pee out 180 liters of urine every day. We only pee out between 1 and 1.5 liters, or depending on how much we're drinking. And the reason is the rest is all reabsorbed, along with all the nutrients that need to be reabsorbed, and then whatever is not needed by the body is what is then eliminated from the body. So there's lots of reabsorption, there's a little bit of secretion, there's some excretion, and then in the end you get about 1 liter to 1.5 liters of urine after passing through all of this. Okay, so kind of gives you a little more detail as to how the blood comes into the glomerulus. There are these little things called podocytes. Podocytes become important when you're dealing with nephrotic syndrome, because that's where the damage happens, which kind of which is what causes you to have your leaky vessels and your protein that you see in the urine. And then this is your distal tubule, and these are kind of the areas where you have certain hormonal secretions that we'll talk about in a bit. All right, so let's talk about your proximal tubule for a bit. This didn't come out right. So what does a proximal tubule do? It absorbs about 65 to 80% of your sodium and water. All your glucose, your amino acids will be reabsorbed here. Potassium is reabsorbed, bicarb is reabsorbed, hydrogen ion is secreted, and the fluid that leaves is isotonic because there's equal amount of absorption of solute as well as water in this tubule. So this will help you understand people who have proximal tubular damage, whether it's from Fanconi's or something else, as to what all will they be losing and what all will you need to replace in them. All right, then come your loop of Henle, which is down here, your descending limb and your ascending limb. Okay, so your descending limb is only permeable to water. So as I'll call it urine for lack of a better word, as your urine is going down this tubule, there will only be water absorbed, so it kind of gets as concentrated as it goes down the loop of Henle. And then this is helpful in establishing a hypertonic interstitium. So as you go down this way, this is your interstitium out here. The more hypertonic as it is, the more concentrated you can make your urine. If for whatever reason it might be, if you are drinking a whole lot of water or don't have enough nutrients or have been not taking enough nutrients or kidney damage for whatever reason, and your interstitium is not as hypertonic. So how hypertonic can your urine get? Anybody know the answer to that? Everybody's forgotten renal physiology? That's quite sad. Students? You can concentrate your urine up to 1200 milliosmoles, technically. Does it always happen? No, because it all depends on how concentrated your medullary interstitium is. So if I drink about 15 liters of water a day, say, and I'm peeing out, obviously, I'm not going to keep all 15 liters in, I'm peeing out about that much, supposedly. So I've sort of washed out my medullary interstitium. So my medullary interstitium will probably be just about at 600 milliosmoles, which means I will not be able to concentrate my urine more than 600 milliosmoles. And the reason why I'm bringing that up is when we have these patients who come in who drink a lot and pee a lot, and then we get worried about whether they have DI, and we try to water deprive them to see whether they are concentrating or not, we will not be able to get their urine up to 1200 milliosmoles in those 24 hours, even if you don't let them eat or drink anything for that amount of time, because their medullary interstitium is not that concentrated. You will see a difference in gradient, but it won't be up to 1200 milliosmoles. So and it takes a little while to build this back for whatever reason you might have lost it. All right, so that brings us to the thick ascending limb, and so this limb was only permeable to water, then this was solute in water, and then the thick ascending limb is impermeable to water. And this is kind of a magnified view. So the main transporter that you all need to remember and will be of value to you is your NK2Cl cotransporter. And the reason I say that is because it is a transporter that's Lasix sensitive. That's where your Lasix acts and blocks this transporter. So when you give someone Lasix, you are losing sodium, potassium, as well as your fluid from the osmotic gradient. The recycling of potassium in this limb happens through the Romke channel. Another thing that you might see, patients who have Bartter syndrome kind of have problems with your CLC channels or your potassium channels in this area. And then you have paracellular transport that happens for magnesium and calcium. So if you were to block just this particular channel right here, then you are going to cause a problem with absorption of magnesium, calcium, and the recycling of potassium. So this is kind of regulating everything else. So when you give someone Lasix, you don't just run into problems with fluid, you can run into problems with potassium, magnesium, as well as calcium. All right, brings us to distal convoluted tubule. So distal convoluted tubule has your sodium chloride cotransporter. That's the transporter that is sensitive to thiazide, another diuretic that you have hopefully heard of and used or will use in the future. Another channel that's kind of important to keep in mind, because if you think of where it acts, then it'll help you remember how it functions and what problems can it cause. This distal convoluted tubule is also impermeable to water, so the fluid that leaves is always hypotonic. So because there's absorption and secretion of solutes that happens, but the water never changes, and then it kind of goes to your collecting duct. Your collecting duct is where your main concentration of urine will happen, because there are channels in your collecting duct that are called aquaporins that are sensitive to ADH, and that's sort of what helps how concentrated or dilute your urine will be based on the ADH component of concentration. So if somebody does not have any ADH or vasopressin, has DI, which could be central or nephrogenic. So if you have central, you don't have ADH. If you have nephrogenic, means the ADH is not acting on the kidneys. Then this is the area where all the water was supposed to be absorbed and now will not be absorbed, and so you'll have a dilute urine that will go out of the kidneys. You also have your principal cells that kind of secrete potassium and reabsorb sodium. That's aldosterone dependent. So this is where that exchange takes place. And so your spironolactone and your potassium sparing antibiotics kind of act in, not antibiotics, diuretics kind of act on these cells in particular. Then you have your intercalated cells that secrete hydrogen and bicarb. So that's where your acid-base role comes into play. So if your body is acidotic, then there will be more bicarb production. If your body is alkalotic, then it'll secrete more hydrogen ions. So this is kind of dependent on what your body is doing, and also whether your kidney is functioning appropriately or not. Because if you have chronic kidney disease, or if you have renal scarring, or if you have ATN, then you'll lose all these mechanisms, and that is what then you'll have persistent alkalosis or acidosis in the body, because you'll lose your correcting factor. All right, that kind of brings us into this slide. So your bicarb is reabsorbed in your proximal tubule, and it's generated in the collecting duct. Then you have your ammonia production that kind of helps buffer your hydrogen secretion. Unfortunately, if we were to be able to measure the ammonium production in the urine, it would be very, very easy to diagnose renal tubular acidosis in patients. But most of the labs do not measure ammonium. There are only some research labs that do. So we have to kind of go by the roundabout way. Whoever is trying to diagnose renal tubular acidosis, and you have to measure sodium, chloride, bicarb, and then indirectly figure out how much ammonium is being excreted. That kind of helps figure that out. So that's another important function that the kidney does. All right, questions about any of the lots of information that I just gave you?
What determines the medullary concentration? So like when you get Lasix washout, is it the proximal tubule?
So, well, if you get Lasix washout, then you're kind of blocking that little channel, which is absorbing your sodium and your potassium, and then whatever you absorb from the luminal side of things does not, let's see. So whatever you absorb from this side of things then gets exchanged to this side of things, and some of it will go into the interstitium. So if you're not absorbing from here, then you're not going to make it go here, and so that'll kind of alter everything. Yeah, it's mostly the meeting. Any other questions? All right, well, what does kidney do as an endocrine organ? So erythropoietin is synthesized by the interstitial cells. It kind of stimulates the bone marrow to convert the erythroid precursors into red blood cells. So when you have kidney problems or you have interstitial fibrosis, you will not have production of erythropoietin. So all your patients who are chronic kidney disease patients eventually will have anemia and will need exogenous erythropoietin to help it work. You can give as much erythropoietin as you want exogenously, but if you don't have any iron in your body, it's not going to work. So you have to have iron for the production of red cells. And so you have to give them iron simultaneously for the erythropoietin to work. So that's one important thing. Anybody who takes care of any CKD patients will know that they're on erythropoietin. There are various different kinds of erythropoietin that you can now replace them with. So vitamin D production, activation of vitamin D is another important function of the kidney. The proximal tubules produce 1-alpha hydroxylase, which converts the 25-hydroxyvitamin D to 1,25-hydroxyvitamin D. It is important in maintaining the calcium and phosphorus homeostasis, not only in the kidney, but kind of also helps with the absorption from the gut. And it also sort of helps regulate the parathyroid hormone, because if you have abnormalities in your phosphorus and calcium, then that's going to rev up your parathyroid hormone to help fix those problems and will cause bone resorption. And so that becomes important as you lose your kidney function to replace that vitamin D exogenously, so that you don't lose a whole lot of bone phosphorus and you don't get a whole lot of secondary hyperparathyroidism. So normally when we as nephrologists check for vitamin D levels, we will usually check the 25-hydroxyvitamin D level, because the 125-hydroxy is very labile and its value varies depending on what time of the day you're checking it and how long it takes for the lab to run it, etc., etc. So 25 is a more stable lab to check and replace. All right, this kind of helps us understand that a bit more. So you have decreased calcium in your extracellular fluid. Parathyroid hormones will increase your parathyroid hormone. Your glands will increase your hormone, which will act on the kidney, your bone, and your intestines. And it'll increase calcium absorption, it'll increase phosphorus excretion, but then it'll also cause bone resorption. So that is why if you just actually keep your calcium and your phosphorus in good control, you will help the bone from not being resorbed. Because once this hormone gets activated, it won't know the difference as to where the calcium is coming from. It's just going to want to fix the calcium in the extracellular fluid. Another thing to remember that we're probably not going to talk about in this talk, but I want to throw it out there, is if somebody comes into you in renal failure and their calcium is really low, and their phosphorus is high. Say somebody comes in whose creatinine is 8 and a BUN of 150. Their phosphorus is 8 or 9, and their calcium is maybe 5. Don't replace their calcium. All they need is dialysis or any form of renal replacement therapy. If at that point in the face of hyperphosphatemia you replace their calcium, it's just going to bind with all the phosphorus and precipitate in their vessels, which will do no one any good. So, and as you dialyze them, their calcium comes up automatically because then it's not bound to the phosphorus anymore. All right, renin is another a hormone that's produced by the JG apparatus, and it converts the angiotensinogen to angiotensin 1. And it initiates the cascade that results in angiotensin 2 and aldosterone production. This is an important regulator in blood pressure. So it's secreted by the JG cells, which is kind of in the, it's between the diagram that I showed you where the afferent and the efferent arterioles are. And the reason why it is very important is that if you had any form of renal injury, whether it was when you were neonate or a fetus or later on in life, or if you had bad reflux and you had scarring from recurrent UTIs, you may end up secreting a whole lot of renin that may result in high blood pressure. In those cases, your renin blockers or your angiotensin inhibitors are the best medicine to use to control the high blood pressure. And this is something we can check whenever we're evaluating for somebody for high blood pressure as well. All right, so this kind of summarizes that if you have when your blood pressure falls, your renin is activated, it converts your angiotensinogen to angiotensin, then it goes on to angiotensin 2, which kind of tells your adrenals to produce aldosterone. Aldosterone in turn will hold on to sodium and get rid of potassium, and that'll kind of help with blood pressure rising. Questions about any of the endocrine functions? Shelly Brown.
Oh, I do have a question. It's not about that, but
You can still ask.
calcium phosphorus product right in children like the goal
Not much. Maybe by half?
or half?
What are the adult norms for phosphorus?
Let's see, 55 calcium phosphorus product.
So the product itself we don't pay too much attention to. We kind of look at calcium and phosphorus individually. The goals that KDOQI and all have set for us don't sort of include the product itself. Because you have to have, so you want their phosphorus to stay normal though. Ideally you want it to stay between 3.5 and 5.5. And so even if they're even if their phosphorus has not gone as high as 6, 6.5, but you know that they have chronic kidney disease stage 3, you want to put them on binders because you don't want to get to the point where their phosphorus gets high and then their parathyroid gets activated.
So like phosphorus, something that has calcium, is that okay?
That's okay as long as your calcium's not high. First line is usually, first line of your phosphorus binders are usually your calcium-based binders. You start with Tums and then you go to Fosrenol or calcium acetate and then move on from there. And unfortunately, insurances are getting more and more stringent. So unless you have not tried those measures, they will not let you use all the other medicines. So, all right, now we come to kidney development. Hopefully everybody is still awake because this might put them to sleep anyway. All right, so your kidney is sort of formed from two main areas. You have the ureteric bud that kind of pushes into the mesenchyme, and then you have your ureteric bud tips. And so if this was not to develop or this was not to develop, or for some reason they don't contact each other, there will be kidney malformations. So, and then branching happens, and then your mesenchyme and then your metanephros and all that kind of falls into play. I won't go into too many details, otherwise I will definitely put you guys to sleep. All right, and then your tubules form and all that happens. So the reason why, just to remember this part, is that you can have problems with your drainage system, and that is enough to cause problems with your actual kidney tissue, your cortex and medulla as well, because of the problems that happen with the formation of your ureters and your ureteric bud. And then eventually branching happens, and then all of these collecting ducts are formed, and there's your little nephron. Okay. Nephrogenesis is complete by 34 to 36 weeks gestation. Again, just keep that in mind when you take care of your little preemies in the NICU. It results in about 0.7 to 1 million nephrons per kidney. And so malrotation of nephron begins in the juxtaglomerular extension and then kind of extends outwards towards the renal cortex. So when it's forming, if you can kind of visualize this, it kind of twists and turns over itself as the tubules form, and that's how the nephron kind of has its little shape that it has and all the little convoluted tubules that it has. So your urine production begins at about 10 to 12 weeks gestation, and it's approximately 5 mLs per hour by 20 weeks gestation, and accounts for about 90% of the amniotic fluid volume. So whenever pregnant women go for their prenatal care, their amniotic fluid gets measured. If it's low, then they pay special attention to looking to see if the kidneys are forming normally or not, because that might be one indication that there's abnormalities in the kidneys. By 40 weeks gestation, the urine volume is about 50 mLs per hour. That's a lot of urine, and there's only that much room in the amniotic sac. So that's how when you see those, I don't know if I call about it, yeah. That's how when you see those ultrasounds that are done right towards the end of the pregnancy that say mild hydronephrosis or pelviectasis, which is even with before hydronephrosis, those all usually resolve. And it's basically because of the fact that there's so much urine being produced that there is definitely some backflow. So it's always a good idea, one, to get another ultrasound and maybe for 1 to 2 days of life, and then repeat it in 6 weeks before really worrying about it, because it's just because there's not enough room for the urine to go anywhere is why they're having that hydronephrosis. Okay, so talking a bit about the renal blood flow, your adult kidneys receive about 20 to 25% of your cardiac output. Fetus receives about 3 to 4%. So when you're a fetus, your renal pressure is really low and your resistance is really high. But as you're born, that sort of slowly reverses to where your renal blood flow doubles by about 2 weeks of age and reaches mature adult by about 2 years of age. So it kind of is a slow process, and that's why everything is different. Your glomerular filtration rate is different, your GFR is different, and all that kind of stuff. So it kind of goes up and goes to normal values from 1 to 2 years of age. So when you check a creatinine when somebody is a newborn, the creatinine that you get is actually mother's creatinine, because that's what was circulating through their blood. And in a full-term baby with no other problems, it takes about 2 weeks to decrease to their own creatinine value. So GFR in neonates kind of correlates with the gestational age and body weight, and parallel increases in renal mass. Again, the younger you're born, the less your renal mass is, because your kidneys are still developing, and the longer it'll take for you to increase your GFR and reach the adult levels, and kind of have a little table that sort of helps you. So this right here is when you're born 25 to 28 weeks, then 29 to 34 weeks, and this is your term baby. So kind of just to help you understand, in week 1, your term baby has a GFR of 40. But your preemie has a GFR of 11, you're less than 28 weeks. It's almost a quarter of what your term baby has. And again, something to keep in mind when we give them all those poisons that we give them, and how we calculate those doses and what we do with them. So they are bound to have renal injuries even while their kidneys are still forming, which can actually result in more problems later in life. And then it also takes them really long to get to the normal GFR. So these kids, the term kids, have reached close to a normal adult GFR by the time they're around 8 weeks of age, more than 8 weeks, about 2 to 3 months of age, whereas the preemies are still kind of halfway through. All right. So in neonates, your autoregulation is highly dependent on the balance of vasoactive and vasoconstrictive factors. So anything that happens to them, whether it's hypoxemia, or you have to give them NSAIDs or indomethacin for their PDAs, etc., or you have to use ACE inhibitors for whatever reason, all of those tend to be, the neonatal kidney tends to be more sensitive to them and is harmed by them. When they're first born, they have a high concentration of all of these hormones because of the little perfusion pressure that they have when they're a fetus, and so it takes a little while for them to go back to normal as well. whenever their mothers are given glucocorticoids for lung maturation or something, that kind of also helps, accelerates the neonatal GFR maturation. Let's see. All right, and then like I mentioned, hypoxia can kind of alter all of what the kidney development that is going on. So in essence, neonates that end up with reduced GFR will then have other problems and other outcomes. So there were studies that would show that the neonates that had kidney problems and had a hard time, did not get, their kidneys did not mature like a normal term baby should, had worse neurological outcomes as well, probably because of the way the electrolyte abnormalities then followed the sequelae. Again, keep in mind, I know whoever's gone through the NICU already knows that whenever you give somebody indomethacin for PDAs, etc., you kind of keep a close eye on the urine output and the creatinine and everything else to make sure that that all is like it's supposed to be. All right, any questions about neonatal stuff? We're going to talk a little bit more about creatinines. No? All right, let's assess the normal renal function. How do you figure out how do you know what someone's kidney function is? Bad answer. I should have put that question in there. How do you know what somebody's kidney function is? What do you look at?
What did she say?
She said call the nephrologist.
Okay.
I said bad answer. Creatinine. So creatinine is the value we look at whenever we want to look at somebody's kidney function. And it's really not the best marker, but it's sort of the only marker that we have available. Because creatinine overestimates your GFR or your kidney function because it is also secreted as well as, So, but that's the only marker we have, and we don't really have necessarily a better marker. So your creatinine, based on, again, your gestational age and where it falls, is kind of here. So when you're born, your creatinine is your mommy's creatinine. Then as the weeks go by, you kind of normalize. So your term baby will normalize to their own creatinine in about 8 weeks. Your preterm babies can take up to 2 months or 3 months. So their values will be higher. The values that are in the computer are not always representative of what the baby's age is. So it's a good idea to always either open up Harriet Lane or your neonatal handbook to look at what the creatinine should be. Yes, Shelly?
If mom's creatinine is high, is there some kind of correction that you can do to determine baby's creatinine at birth, or do you just wait?
No, you have to wait. Yeah. All right, so these are sort of the normal values that you can have. I put 0.3 to 1 because obviously if you check it in the first hour of life, it will be high. And then it kind of goes through depending on what their muscle mass is and what their creatinine should be. So if you have a patient who gets admitted to the floor and their creatinine when they came in was 0.3 and goes up to 0.6 during the course of their hospitalization, their kidney function has gone down by half because their normal creatinine was 0.3 and it's now up to 0.6. 0.6 may not seem very significant to us because, hey, 0.6 is a normal creatinine. But if somebody's starting creatinine was 0.3, their kidney function is already down to 50% of what it was. It is very important to keep that in mind with all the medications that we use and dose and antibiotics that we give, particularly vancomycin, tobramycin, and all those antibiotics that kind of can cause more damage to the kidney. So that's something you really have to keep in mind. If it goes from 0.3 to 0.6, it will not show up in red in EPIC. You have to keep an eye on it. All right, so creatinine is the best value we have that we use for looking at kidney function. So lots of the glomerular filtration or GFR measurements or kidney function measurements that we do are also based on creatinine. So obviously they kind of overestimate your kidney function because they are also secreted by your glomerular capillaries. And it is also extrarenally secreted. So some of the creatinine is also secreted by your intestines, and that function is taken over more whenever somebody has chronic kidney disease. So it's kind of the best marker, but not really the best marker. If you really want to check somebody's creatinine clearance and you're going to collect their urine for 24 hours and you want to sort of minimize the secretion of creatinine, you can give them cimetidine for about 2 days, and that seems to decrease the amount of tubular secretion that happens and may give you a closer measure of the glomerular filtration rate. Okay. So normal GFR glomerular filtration rate is about 100 to 125 pulse per minute per 1.73 meters square. Gold standard is inulin clearance, which is only done in research. The reason why inulin is best is because it is freely filtered, it is not secreted, it is not reabsorbed, it is not metabolized. The problem is checking inulin clearance requires a lot of blood draws and a lot of urine sample collections, which especially when you have younger kids, is really hard if they're not potty trained. So it's really not practical to do so. So we kind of rely on our creatinine clearance, which we can either do by a 24-hour urine creatinine, or we can do by what's called a Schwartz formula, which is the easy formula that you can use at the bedside whenever you are called and said, you send down the MRI questionnaire, but where's the creatinine clearance? It only takes a minute to calculate it. So your 24-hour urine creatinine clearance, which is a little more accurate than your Schwartz is. Schwartz is easy to use for when you need it urgently to either calculate medication dosages or get their scans and MRIs done. But if you really want to assess somebody's kidney function to figure out whether they need to be on dialysis or whether you need to refer them for transplant, then you kind of need to do a 24-hour urine collection. So you need all of these values. You need your urine creatinine concentration and your total amount of urine, or you need your total amount of creatinine. And this is kind of the formula. It is inherent clean. It sort of walks you through it, so it's really easy to calculate. All you have to do is open up the page and look at it. And I'm sure there are many apps on iPhones that let you do that too. So you have to, the important thing about calculating creatinine clearance is because our kids are not a body surface area of 1.73, and this formula is kind of normalized. It is for a 1.73 body surface area person, so you have to correct it for the patient's body surface area. So besides knowing all of these things, you also need to know the body surface area of the patient. This is your Schwartz formula, and it's an easy bedside formula. You need your height in centimeters, you have a K that's constant, and your creatinine, which are mostly values that you can easily get from Epic. This is a constant, and I left this on there is because I think Heret Lane still has all of these constants. They have now revised this formula to where you can just use 0.41 for everybody, whether they're a little child or a 15-year-old. So you don't have to remember these constants anymore either. And then that way you can calculate that GFR that they need for your various exams. Okay, so cystatin C is another something that's has been up and coming for a while to sort of improve creatinine, because it was like, well, creatinine is what we have, but it is not the best estimation of kidney function. So let's put cystatin C in there. So what is cystatin C? It is a non-glycosylated cysteine protease inhibitor protein that is produced at a constant rate and is freely filtered by the kidney, is catabolized and completely reabsorbed by the proximal tubules. So your normal cystatin C level is 0.8 to 1, which is sort of easy to remember because it's about the same as what your creatinine values are in a normal adult. The problem is prematures have a higher level. There is difference in level depending on what method you use to calculate cystatin C. And then when you have heavy proteinuria or glomerular injury, you will find urine cystatin C as well. And so if you have a high CRP, if you're on immunosuppressive therapy, if you have diabetes, thyroid dysfunction, all of that kind of factors into altering cystatin C. So, and these are the populations where you would want to get an accurate measurement of your GFR, and so it kind of helps us some, but not really. So CKID is our major big study group that we have, and they decided, well, we need to come up with a better way to calculate our creatinine clearance. And so they combined creatinine, BUN, and cystatin C and sort of derived a formula, but they only tested it in chronic kidney disease patients. But this is that formula. Who wants to remember it? Even I don't remember it. And I hardly ever use it. So this is the formula they came up with. So you need to know the height, you need to know serum creatinine, you need to know their cystatin value, their BUN, and then you kind of normalize for all of these and do all your logarithms and then come up with the value. But our creatinine clearances based on creatinine as well as Schwartz are close enough where we still haven't run into problems. But unfortunately, it would be nice to have a marker where we could figure out what their kidney function is doing on a day-to-day basis, because your creatinine values will lag behind, your urine output will sort of lag forward, and if we could come up with a marker that would just help us follow their kidney function, it would be nicer. Because by the time we make our changes for our drug dosages based on the creatinine we got this morning, their kidney function is already changing and we're kind of behind the ball. We can use certain radioisotopes to measure kidney function as well. None of them are used here. We used to have iothalamate whenever I was in my residency, and we used it a lot, especially to kind of follow the kidney function for our transplant patients. They are both, like inulin, iothalamate also requires blood draws, but it's about 4 blood draws over the span of 4 hours and some urine samples. And now there have been studies actually where they realized that iothalamate stays stable for a long period of time. So you could actually just inject that one-time injection and send patients home with lancets and filter paper, and they can just get those blood samples for you and they should mail them to you. So it can become widely used, but it's still not widely used. But it's a good measure of kidney function. And these are my references. I like this one. Questions? Shelly?
That was amazing.
Any questions?
Yeah. Why are you so awesome?
And not. Next. No questions? All right. Well, if you come up with any questions, you guys know where to find me. I'm pretty sure by now everybody has my cell phone number.